Thank you for the invitation to speak this and the kind introduction and the incredible honor of the McNulty Scientist position. I'll pull up some slides here. All right, can you guys see those okay?
Yes, no, we're good.
Excellent. So I'd like to talk to you tonight about pediatric hydrocephalus and the post-traumatic stress symptoms that may come along with that. And I want to give you an introduction to what it is that we do primarily in my group here at the University of Alabama, Birmingham. So first off, let's define the terms. What is hydrocephalus? Well, hydrocephalus is an accumulation of spinal fluid in the brain. So on the right side of this picture here, you can see an MRI scan of a brain. These black spaces in the center of the brain here, these are the ventricles, and they're filled with cerebrospinal fluid. This is a normal appearing brain. But on the left side, you can see that these ventricles are quite enlarged. This is actually the most common problem that we treat in pediatric neurosurgery. It makes up about 50% of the volume of cases, of surgical cases that we do in our field nationwide. So hydrocephalus is an incredibly common problem. Now, untreated, hydrocephalus is almost always a fatal condition. These pictures I've kind of stolen from the internet, but there's some examples of what happens to infants with untreated hydrocephalus. You get an unchecked brain growth, or excuse me, unchecked head growth, and really these heads are completely filled with fluid, and there's no room for the brain to grow at all. So prior to 1958, hydrocephalus was, as I said, almost universally fatal. 9 out of 10 kids born with hydrocephalus would die, and the other 10% would have some pretty significant intellectual disabilities. So the innovation in the 1950s was the invention of the ventriculoperitoneal shunt. So this is a pretty simple tool. It's just a tube where one end goes into the brain, into that fluid space in the middle of the brain. There's a valve that allows the flow, controls the flow, so it's only one direction. And then there's a distal catheter, a tubing that goes typically into the abdomen, the peritoneum. So all that excess fluid can drain into the abdomen. With shunting, with the VP shunt or VPS, kids can live essentially a normal life with hydrocephalus. So this has been a revolutionary treatment for hydrocephalus, again, around since the 1950s. Here's a schematic of how we put these shunts in. You can see that there's the catheter that goes into the ventricle. It's tunneled underneath the skin. And again, most of the time we put this bottom end of the shunt into the abdomen. Now, the problem with shunts is that they're a simple system. They're just a tube and they can fail. What I'm showing you here is a classic survival curve. So on the x-axis here is time. So from the time that the shunt is placed, 1, 2, 3, 4 years. And on the y-axis is the proportion of shunts that are still functioning. So as you can see, if every shunt that was placed was working fine, we'd see a nice straight line across the top of the screen here. But that's not what the reality is. The reality is that after we place a shunt, they start to fail almost immediately. So the average shunt, right, if we take 100 kids, 50 of them will have their first shunt failure right around 2 years after we've put their shunt in. Now, how do shunts fail? Well, they just get clogged up with brain material. And when that happens, kids can become pretty profoundly symptomatic again. So the shunt blocks, they can have a really wide range of symptoms. From the most benign, some kids will have a mild headache, maybe a decline in school performance. It'll be pretty tough to tell that they've had a shunt malfunction, versus the other end of the spectrum. Some children will become comatose and can die within hours. And there's really no way to predict when your shunt fails, if you're going to have the, kind of more benign type of shunt failure, or if you're going to have one of those much more dangerous types. It's also completely unpredictable when that shunt is going to fail. I showed you that picture a minute ago of, we can estimate 50% will fail by 2 years, but we really have no idea when this will happen. So to summarize hydrocephalus, it's treated primarily by shunts, by VP shunts. These shunts can fail at any time. The shunt failure symptoms can be quite mild, or they can be quite severe, and it's extremely unpredictable. So now imagine yourself as a parent of a child with hydrocephalus, And this is reality. When your child has a headache or maybe nausea, some vomiting, you don't know whether this is a shunt problem or just a run-of-the-mill. Kids get headaches all the time. So I want to change gears really quickly here and talk a bit about something that most people are rather familiar with, and that's PTSD, or post-traumatic stress disorder. Now, we know that PTSD happens in contexts like the military, when you've seen terrible things happen, or if you've experienced a trauma or seen like a physical trauma. It can also happen really if just bad things happen to you. But it turns out that encounters with the medical system, simply going to see the doctor, can be quite traumatic for children, to the point that sometimes kids and parents will have post-traumatic stress disorder or post-traumatic stress type symptoms simply from encountering a physician. And that's a phenomenon that we call pediatric medical traumatic stress. So there are psychological and physiologic responses in children due to pain, injury, illness, etc. Now, we know that this exists because there have been some good studies done on children with cancer, children with diabetes, or children who have had a traumatic injury, a car accident, etc. But we don't really know much about pediatric medical traumatic stress in the setting of hydrocephalus. We also know that medical traumatic stress has an impact not just on the child, but on the family. It can lead to a reorganization of family roles and tasks, big shifts in attention, how caregivers work, and then, of course, there can be problems with other members of the family, guilt, etc. When you look at those studies of pediatric medical traumatic stress and things like cancer and diabetes, there are some risk factors, some features of the disease that tend to make this medical traumatic stress more likely. So a specific scary or shocking event, a painful medical procedure, separation from caregivers, for example, if you have to go to the operating room, right? If there's a physical limitation or an impairment like a neurologic impairment, uncertainty about the outcome, caregiver helplessness, or perceived threat to life. And when you look at these list of risk factors, it really lines up very well with what we know parents and kids with hydrocephalus are going through. There is, again, they live with this shunt that does its job most of the time, but when it fails, it can be quite severe. So this led us to the main study that I want to talk about, and that is our study of pediatric post-traumatic stress in hydrocephalus. Now, the central premise that we're exploring here is that this is the hypothesis that exposure to treatment of hydrocephalus and living with hydrocephalus can put children and their parents at risk for post-traumatic stress symptoms, or potentially even post-traumatic stress disorder. So to study this, starting in 2017, we administered a checklist, a post-traumatic stress disorder, a PTSD screening checklist, to all the families in our clinic with hydrocephalus, or at least a sample of them. About 150 parents participated in this. So what you can see here, this is the higher scores here are worse post-traumatic stress. And at first, this looks encouraging, right? Most of the scores are clustered at this lower end of the spectrum. They're having less post-traumatic stress symptoms, and their average score is about 17. So it looks pretty encouraging. But if we pay a little bit more attention, 33 is the cutoff for severe post-traumatic stress symptoms, worrisome for true post-traumatic stress disorder. And 14% of our caregivers had scores up here in this post-traumatic stress disorder range. And that's a fairly large chunk of our sample. The other thing, however, that we learned that was very important, when you talk about post-traumatic stress, this screening questionnaire that we used, it is not specific to hydrocephalus or to pediatric medical care. It's a generic PTSD screener. So it asks, what is the most traumatic event in your life? You can't have PTSD if you don't have some type of trauma. So this is a free text field where families can just enter in what is their most traumatic event. And what we get is a lot of discussion of their child's hydrocephalus. There's some examples, some quotes that we got from this survey. And if we break it down, you see that over 50% of these families that took this post-traumatic stress disorder checklist, over 50% of them said their child's hydrocephalus was their biggest life traumatic event. Some of them did not indicate an event, others never had one. and some had traditional traumas, military service, death, witnessing death, etc. So this tells us that their encounters with us, their encounters with the medical system and with their child's disease are a very relevant part of their lives. So what can we do about this? How can we intervene on this? And this is where we come to another concept called resilience. Now, of course, everyone knows what resilience is, right? This is how well you can deal with adversity. Well, it turns out resilience can be quantified as well. So as we were screening for post-traumatic stress disorder, we're also screening for resilience. And here you can see our survey of the caregivers. These are the parents. And again, things are looking pretty good here. You can see that most people are scoring in that high resilience range, right? Looks pretty good. But I'm going to come back to that and tell you that it's not that good, right? And when we actually ask the children, these are among the children who are old enough and capable of answering these questions themselves, their resilience scores really run the entire range from extremely low to reasonably high. But when we talk about resilience, it's not just the absolute score that we're interested in. The way that this measure is designed is your scores break down into quartiles. So if I take a sample of people and administer this test, 25% of my patients should be in each quartile, the first, second, third, and fourth. And that's not what we found. What we found instead was that among the caregivers, 37% of them were in the lowest quartile, had the lowest amount of resilience according to the standardized scores. And even worse, when you look at the children, 62% of them were in the lowest quartile. We expect 25%, we have 62%. So that tells us that this group has low resilience. Now, the nice thing about that is that resilience is something that we can target, something that we can intervene on. So in summary, what we've learned so far is that children with hydrocephalus, their parents in particular, are at quite substantial risk for post-traumatic stress. And resilience is a potential target for an intervention that might be able to help the situation for both parent and child. So, of course, once we know this, the next question is, what are we going to do about it? And this goes to the work that we're doing now. There is a group at the University of Washington in Seattle that has created this intervention called PRISM, which is Promoting Resilience and Stress Management. Now, this was designed for children with cancer, and they showed in a randomized control trial that they could markedly improve resilience of children and of parents who are dealing with a medical condition using this relatively simple intervention. This involves a couple of sessions of essentially like counseling or group discussions, and then a smartphone app that they can continue to work on resilient skills using. So we are set up to now tailor that PRISM intervention for our parents and families with hydrocephalus. And we will be rolling out a pilot study of the PRISM intervention in our clinic starting in 2022. And of course, part of the support that we need to get that pilot study going comes from the Civitan McNulty Award. So again, I'm very grateful for your support. The Hydrocephalus Association is a national organization that reaches people with hydrocephalus really around the country and around the world. And ideally, we are partnering with them as we develop this PRISM intervention. And in an ideal world, we'll be able to roll this out to a national or international audience using the resources of the Hydrocephalus Association. And of course, in the meantime, we need to continue screening our patients here in Birmingham and hopefully at other centers around the country as well, so that we can identify these psychological comorbidities that impair their response to treatment and their quality of life, and intervening on these things that we don't necessarily always think about when we're thinking about a surgical condition. So to conclude, what I take away from this is that if we pay attention to psychosocial factors, we can improve the quality of care and potentially improve outcomes in pediatric neurosurgery. And with that, I will stop and I will take any questions from the audience. Thank you very much for your attention.
Thank you, Dr. Rocque. Really very informative, very interesting. If folks have a question, if you could either raise your hand, and then what we'll do is identify you, or type that you have a question in chat, and then we will then read that question out. Okay, question from Joe and Joanne O'Toole. Can this be determined before birth?
So that's a great question. So sometimes hydrocephalus can be diagnosed before birth, but that's actually quite rare. Most hydrocephalus develops after birth. It is most common in infants. So children who are premature and have a hemorrhage in their brain, that's a very big risk factor for hydrocephalus. Children with spina bifida also commonly develop hydrocephalus, and there are a number of other reasons. So most kids develop hydrocephalus in infancy. Rarely we can diagnose it before birth, but most of the time it's not present until after they're born.
Okay, then we have a question from Chip Woods. What is the expected period? What is the expected period of support with PRISM?
So PRISM, the intervention, it is 6 short sessions that we administer with a PRISM coach, with a resilience coach, and those are about a 1 hour sessions. And then after that, there's the ongoing interaction with the PRISM app. The idea is that we're developing resilience skills that can be used, in an ongoing fashion.
Okay, a question from Mary D. Cohen. What do families need the most while going through the medical process treatment with your child?
That's a great question. And this is something that we tried to study as well. As we were realizing just how important some of these psychological and social factors are in quality of life, we did a handful of interviews, about a dozen, 18 interviews with families, really try to nail that down, try to get feedback from them about how do we as neurosurgeons provide you with the best possible care so that we can give you the support that you need. And the answers that we got from that, a lot of it focused on information, right? We need to know more about our child's hydrocephalus, what we can expect from the condition as they grow older. There's a lot of uncertainty, both in whether the shunt's going to continue to function, but there's also uncertainty about how well the child is going to develop, cognitively. Sometimes these kids have pretty substantial cognitive limitations from other brain injuries, and that uncertainty is really challenging for parents. So I think one of the things that we need to be cognizant of is just how much support these families need dealing with this disease.
Okay, I have another question. Thank you. Another question. What is the average lifespan for these patients?
Well, it now depends entirely on other medical conditions. So sometimes children, again, for example, if you're born very premature, that's one of the major risk factors for hydrocephalus. The severity of your prematurity is much more important in determining your lifespan than your hydrocephalus. Again, shunts were first developed in the 1950s, so we really haven't seen kids from that generation live out their full lifespan yet.
You need to fix your Microsoft account.
Then we also have a question. Stent seems very risky. So is death certain without the stent in place?
Well, it is. That's the thing. Before 1958, before the development of shunts, this condition was almost always fatal. So while it is quite risky, and it's very frustrating for us in particular that when we place these shunts, they can become blocked even within a couple of weeks. Some kids are back having another surgery right away. But at the same time, other kids will go 20 years without ever having a problem with their shunt. But what we do know is that if we don't treat the hydrocephalus, if we don't place the shunt, then the patients are going to do much worse. They're going to be at very high risk for death or severe intellectual and developmental disability.
Okay. Another question from Linda Lilly. Why does the stent drain into the stomach?
Well, it actually drains into what's called the peritoneum. So that's kind of the space in your abdomen where your stomach and your intestines live. It's not actually going into the stomach itself or inside the intestines. It just kind of lives in the same space. So what that does is it takes that excess fluid from the brain, it gives it somewhere else to go. And then once it's there, the body can just reabsorb it. So it essentially gets taken back up into the bloodstream. There are other places we can put the shunt, that bottom end of it. The peritoneum, the belly, is the best one. It tends to work the best and have the lowest complications. But we can also put it into the heart. We can put it into the space outside of the lungs. It's called the pleural cavity. Sometimes it can be put into the gallbladder or the urinary bladder. There's all kinds of options, but the belly is the best one.
Okay. Another question. Has anyone ever developed a sensor which can give parents and children a signal of a blockage or the absence of one?
That's a great question. These sensors, people have been developing these for a while. And one of the factors that we can look at is the pressure inside the head. So your skull is a closed box. And if your shunt stops working, you get a buildup of fluid. So the pressure in your head goes up. Now, if we could have an implantable pressure monitor that would tell you when the pressure starts to go up, that would be a way to do this. I know that people have been working on this for the last 20 years, 25 years. And the key is to make the technology small enough and find a way to power it long enough that it can be reliable. So nothing is available yet that can be used clinically, but there are definitely a number of groups who are working on that.
Okay, very good. Another question. Does hydrocephalus ever develop in adults?
It certainly can. It is most common in kids, but it can develop in adults after something like a traumatic brain injury or a hemorrhagic stroke, brain bleed. And sometimes it just slowly develops over time in adults. There is a phenomenon called normal pressure hydrocephalus, which can look kind of like Alzheimer's, which really isn't the same thing as what we deal with in children, but it's treated the same way with a shunt. So yes, adults can get it too.
Alrighty, very good. Do kids that live with shunts have limitations on their activities?
You know, what I tell my patients is that I don't think it's a great idea for them to play football, but I also tell all my other patients that I don't love the idea of kids playing football. It's a sport where you bang your head into things over and over again. And as a neurosurgeon, I'm not thrilled with that. But the answer is it's very unlikely that any kind of sports participation is going to cause a problem with the shunt. So I don't have any major activity limitations for my patients.
Alrighty, then another question. Do kids outgrow this condition?
They do not. As far as we know, once you have a shunt in place, you are dependent upon a shunt for the rest of your life. This is not something that you outgrow.
Alrighty, any other questions? Alrighty. I would say is if anybody has a question that kind of comes to them after Dr. Rocque's presentation is done, we can certainly email him. Thank you, Dr. Rocque. This has really been most informative, really given us a lot of information. Years back, did work with a couple of children that had, hydrocephalus, and it really is kind of a very, very, I guess, very a critical condition. And the one also thing I just have to say, just kind of surprised that usually medical and the psychological don't kind of intermix. So I'm very impressed that you kind of are looking at the whole patient rather than just kind of a part of them.
I very much appreciate that, and thank you for the opportunity to speak to you guys tonight. It's been fun.